Thank you. We have a lot of people here, so definitely a lot to look at and a lot of different roles to speak to, which I appreciate. Just as folks do that, I'll start by providing an introduction about myself. So my name is Katie Eklund. I am currently a professor in the school psychology program at the University of Wisconsin-Madison. I have been a faculty member for 14 years now. I do research in the area of school mental health, primarily in screening and early intervention, and then have also done a lot of work in the area of Tier 2 mental health services, and certainly have been a part of supporting Tier 3 efforts in schools as well. I've served as co-director of a research practice partnership here between UW-Madison and Madison Metropolitan School District. And then prior to my current role, I worked in schools for 10 years as a practitioner. I started my career as a school social worker, and I was a mental health coordinator for a large school district in Colorado, where I supervised and mentored a group of 100 psychologists and social workers, which was an awesome job, and oversaw a lot of district mental health initiatives. I then went back and got my PhD in a combined clinical and school psychology program at the University of California, Santa Barbara. And then went back and practiced for a couple more years as a school psychologist and did some work as a consultant for the Colorado Department of Education. So excited to chat with you all about some of my school-based experiences and as well as some of the research that I've engaged in over the last several years as well. I'm currently a nationally certified school psychologist and a licensed psychologist as well. And so certainly mental health supports are near and dear to my heart and certainly a part of my professional practice and research. So for today, also we'll highlight I'm part of the School Mental Health Collaborative. We are a national research and technical assistance center that was established formally in 2021. We now have 4 universities that support our work here at UW-Madison, UC Santa Barbara, the University of South Florida, and the University of Iowa with the Scanlon School Mental Health Center there. Our aims are research that informs policy and practice and to be able to promote the social, emotional, and behavioral success of all students, and hopefully to create tools and resources that support educators and those who work in schools. So a lot of the resources I'll highlight and point to today are available on our website, which is on the left here, smhcollaborative.org. And so certainly would encourage you to check that out as well. So our focus for the presentation today is we'll start by talking about mental health frameworks that are available to support schools. Going to spend a touch of time, not much, but on universal screening. So really thinking about how do we identify kids and have a better sense of what are the needs of students within our schools, and then how do we connect data to effectively support what types of interventions that students need. We'll then dive into why you came today. So the focus of Tier 3 mental health interventions. We'll talk about cultural adaptations to those interventions, as well as some discussion around what might be good progress monitoring measures that you could consider to address those needs. And then our objectives today, as I mentioned, we'll talk about multi-tiered systems of support for mental health, being able to focus on Tier 3 specialized interventions for youth in schools. Again, we'll think about assessment strategies and then also talk about how can we adapt both Tier 3 interventions as well as other types of school-based interventions to make sure we're increasing relevance for students from minoritized identities and marginalized communities. So the evolution of treatment. I'd like to start with this in mind, thinking about how we haven't started. We're not that far from where we started. So 2000 BC, here eat this root. 1000 AD, that root is heathen. Here say this prayer. 1850 AD, that prayer is superstition. Here drink this potion. 1920 AD, that potion is snake oil. Here, swallow this pill. 1965 AD, that pill is ineffective. Here, take this antibiotic. And 2000 AD, the antibiotic is artificial. Here, eat this root. I think in education, we think about mental health as being brand new or something new that we're adding to our plates, but it's actually been around for quite a long time. When I first interviewed at UW-Madison 8 years ago for my current role, I started doing research on our program, and there was a book written in 1960 on school mental health, right? And so thinking about 60 years ago, 65 years ago, our very ancestors in the school psych program were doing the very same thing. And so certainly we want to have our current practices reflect contemporary practice and best practice work. And so going to talk today about what that looks like to best support the needs of children and families in our schools. So the child and adolescent state of mental health has been defined as a public health crisis. In our research team, we talk about this 2020 phenomena that, which I think would more clearly define as a 40-20 phenomena, that 40% of kids experience some type of mental, emotional, or behavioral symptoms throughout their school trajectory, right? We might say that only 20% of that might be diagnosable, but 40% of kids have some type of need that warrant the help and support of school mental health professionals in school. However, only 20% of those students receive help and support for their needs. So we have a large gap between kids who have mental health concerns and then those who actually receive support for those needs. There was a huge increase in mental health concerns during the pandemic with a spike in mental health related ER visits during COVID. And we've especially seen significant increases in internalizing behaviors, sparking the need for us to be aware of how to address those concerns. When we define mental health, right, our current definition of mental health includes a clinically significant pattern of behavior or psychological functioning that's associated with significant distress or impairment, or a substantially increased risk of death, injury, or loss of freedom. It must not be an expectable or culturally sanctioned response to an event, and must be considered a manifestation of a behavioral, psychological, or biological dysfunction. As we think about it, I think within our field, right, we consider mental health challenges to include both externalizing and internalizing behavior concerns. Many times we see these problems exist along a continuum, right? So as we think about tier 3, we might be thinking about kids who have a diagnosable disorder, who might be in special education or receiving services as part of an IEP, because those concerns have risen to such a significant level. However, those problems exist along that continuum, from low risk to subthreshold symptoms. When we think about our tier 2 services, right, hopefully we're identifying kids early enough when they're showing early signs of withdrawal, sadness, school avoidance, maybe when they're having difficulties paying attention in class. Those would be some of the subthreshold symptoms that we would see that would warrant tier 2 interventions. So thinking about, again, that continuum, and then how do we develop mental health services that meet the needs of those students. When we think about internalizing problems, right, these are often those concerns and problems that are under-identified because of, right, how they come to our attention. We've seen a spike in those in recent years. Anxiety disorder prevalence rates are up to 30% of all children with a median onset of 6 years of age. Mood disorders, about 14% of our population, with that median onset at 13 years of age. Certainly kids who have these types of concerns have an increased risk for negative outcomes. So they're often kids who have difficulties getting along with other kids at school, some challenges at school, and certainly increased rates of suicidal ideation and behavior. And then high rates of co-occurrence. So 69% of anxious youth also meet the criteria for depression, and 75% of youth diagnosed with depression also meet the criteria for anxiety. So we're trying to address multiple needs of kids that are attending our schools. Ann Maston has, right, many of you maybe remember studying the developmental cascades model. Ann's works out of the University of Minnesota. But this diagram here talks about, on the top left, you can see this EXT model, that many of the concerns we're seeing present with kids might start as externalizing behavior concerns, which then can develop into academic problems. Over time, if kids are struggling in school, right, if they're having difficulties listening to their teachers, staying focused and attentive in class, right, they may miss some instruction. And so over time, we see kids who might have difficulty with learning. We see grades that are impacted over time. And if kids aren't being successful at school, those negative effects can start to impact their self-concept, their self-esteem, their motivation to come to school, which over time can lead to this internalizing problem that you see in the bottom right-hand corner. And so certainly important to think about what are the root causes of behavior, what does symptom presentation look like, because it may not always initially start as an internalizing behavior concern, but over time certainly can become one based on a myriad of factors with students. If we're also conceptualizing complete mental health, it's not enough for us just to think about negative symptoms, right? In our traditional medical model of how we define mental health, which looks at aspects of mental illness or emotional distress. So as we've been talking about internalizing problems or externalizing problems such as disruptive behaviors, right? There's other ways that plays itself out. But we also have to think about complete mental health as not only the presence of problems, but also hopefully the presence of positive indicators. We want kids to be happy, right? We want them to feel satisfied with their life, to have strong social relationships, for their basic needs to be met, and to experience well-being. And so certainly we're hoping to decrease negative symptoms and increase positive indicators when we're thinking about how to best support children. And certainly don't want to leave out, right, potential risk factors that can increase rates of mental health concerns. And hopefully we're working to boost those resiliency factors in our schools as well. The good news, as I'm seeing in the chat, is that many of you work in schools. You play an important part of addressing mental health concerns. We know that if kids are going to access mental health supports, that they're most likely to do so at school. And so it's certainly important for us to think about how do we identify and meet those needs of students. I'm looking at all of the different roles that you all have here in the chat. We have school counselors, people who are working as administrators, school psychologists. Thank you for all of your work because we know that without you, kids wouldn't receive the mental health services that they need. Within our schools today, right, students from historically minoritized identity make up over 50% of the school-aged population with projected increases. However, our public school teacher workforce is 80% white and predominantly female. The same is true of our school mental health workforce. Certainly school psychologists have similar rates. And when we think about addressing the mental health needs of our students, it's important to be aware of that cultural mismatch. There's a disproportionate number of students from minoritized identities who are identified for services due to an emotional disability, which is often where mental health concerns lie. And our school demographics can differentially impact those rates of identification and access to services for students. So as we talk today, I'll be highlighting and pointing out equitable practices and thinking about ways that we can work to hopefully decrease rates of disproportionality in our schools around identification of both mental health concerns and emotional disabilities, with a focus on prevention, early intervention, and equity-based considerations in the data-based decision-making that we're engaged in. So certainly thinking about what are those strategies we can engage in. Students who have emotional and behavioral problems have poor school-related and longer-term outcomes. Usually these are students who, most of my time working in schools was with middle school and high school youth, and I saw that a lot of these students were involved in the juvenile justice system. They often weren't coming to school, and were students that were struggling to graduate. And so certainly, I think for me, one of the reasons I became interested in this work is when I would go back and look at students' cumulative files, often mental health and behavioral concerns were present as early as kindergarten and first grade. But these were students that, for whatever reason, weren't getting access to services until they were in middle school and high school. And so really calls on us to think about what are those early intervention strategies and ways that we can access and provide mental health services and behavioral supports to students early on. This study came out in 2017 and provides an overview of, on the left you can see in the blue, unmet mental health need and any mental health services. So you can see across 3 studies, we see the percentage of youth in need of mental health services. The dark blue indicates the proportion of those youth who received any type of mental health service, right? So in the Burn study, about 50% of kids had mental health need. Only about 15% of them had those needs met, right? And you can see what that looks like across 3 studies. But in those same studies on the right, so if you look at part B and the green graph, these are data from youth who received any type of mental health services. And you can compare the percentage of services provided by specialty mental health provided with those who are provided by school-based or school-employed providers, right? So when kids did receive services at school, we see that school-employed providers are those most often able to deliver those services to kids, and thinking about ways that we can realign school-based resources to hopefully reduce disparities in how kids are accessing mental health services at school. All right, so what do those models of mental health services look like? When we think about mental health support, our traditional approach has been to remediate social, emotional, and behavioral disturbances among students who are referred to us. A public health approach would call on us to promote the psychological well-being of all students. That includes providing protective support to youth with elevated risks of mental health concerns, both academic and emotional concerns, to promote healthy environments that help youth overcome risk and challenges, right? So thinking about aspects of school climate, thinking about school mental health to student ratios, and making sure that well-being is promoted within our school setting. And then that we also have ways to remediate social, emotional, or behavioral disturbances among students who are referred. So what does that look like in places where we work as well? So multi-tiered systems of support, been around for 20, 25 years. Early models referred to this as response to intervention for academics and positive behavior intervention and support. Certainly in these models, we have a school-wide code of behavior expectations that are explicitly taught to all students and reinforced at the universal level. Students who are demonstrating inadequate response or those who continue to show behavior problems receive some type of tier 2 intervention. That can include focused support programs that are delivered in a small group format, so things like social skills training or check-in, check-out. And then those unresponsive to tier 3 would move to more intensive services, which might include, function-based behavior intervention plans or potential referral to special education. The hope with PBIS is that we're decreasing externalizing problems as well as increasing or promoting positive social behavior. Many schools have also, there's been an uptick in social emotional learning interventions as well. And so in these models, we're often hoping to decrease internalizing problems and increase social emotional skills. So in thinking how to best integrate these models together, right, we want to think about how social emotional learning can be integrated to not only decrease those internalizing concerns, but also promote what we've been trying to work on with PBIS as well. So thinking about ways to interlock those two systems when we think about mental health supports is foundational to this work and critical to this work as well. Mental and behavioral health services, we know, fall on that same continuum and can be provided with an MTSS. So at Tier 1, we're thinking about the promotion of mental and behavioral wellness. We're also at Tier 2 thinking about direct and indirect services to address emerging mental and behavioral health problems and hopefully prevent risky behaviors. And then at Tier 3, looking at direct and indirect services. This next slide is a model that the National Association of School Psychologists put together, actually at this point 20 years ago. But I like to point this out because many of us might think we're not engaged in mental health services, and I find it that's often not true, right? Many of you have multiple ways that you're engaged in different aspects of mental health, which you might not call or think about as mental health. I think when we refer to mental health services in schools, if I'd ask you, if we were in person, I'd ask you to jot down what comes to mind. And usually when I present, people will say, individual counseling, small group supports, right? It's all of those things that involve a school mental health professional meeting in some type of individual or small group format with children and adolescents. And certainly that absolutely meets, what we're talking about in terms of counseling and therapeutic contact to address some of those mental health needs. But there's also a larger range of services that I'd like for you all to consider as meeting the mental health needs of students. So I'm going to share 4 slides, and what I'd like you to do as you're looking at those slides is start to tally and count how many of these do you have at your school and or are you involved in as a school mental health professional. So just keep a tally, and then when I'm done, I'm going to ask you to put the numbers in the chat or to unmute yourself and share a little bit more. So the first level we'll start at is prevention and universal interventions. So mental health services can include social emotional learning, bullying and violence prevention. How do we foster positive relationships among students and staff? What do homeschool relationships look like? How do we help teachers build positive relationships with families and parents in the classroom? What are effective discipline policies and practices? Classroom guidance lessons that many of you may be pushing in to schools to deliver. One of my favorite examples my students shared this year is they're a practicum student, and their school psychologist carves out 2 hours every week where they go into different classrooms. They spend 2 different hours in 2 different classrooms each week, just doing some general social emotional learning and telling the kids, this is who I am, I'm the school psychologist, here's what my role is, and giving the teacher an hour off while they're with their classroom to talk about some type of skill building activity that they do. Not only does it increase some mental health literacy in terms of what the kids are learning, but they also get to know a little bit more about who their school psychologist is and what they do. So thinking about, again, some of that prevention and universal intervention. Early identification strategies, right? So still at that universal level, This could potentially include all students and school-employed mental health professionals, so universal screening, mental health literacy. Do we spend time on data teams reviewing behavioral data? Do we look at attendance data? What does mental health first aid look like? Are we doing anything around suicide screening? Are there protocols for responding to bullying? Do we have self-reporting systems in place or anonymous reporting systems, either at the statewide level or potentially within our district? So again, and these are just examples. There might be other things that you're doing in your school that still fit these categories. All right, our third slide, targeted interventions. So this might include social skills instruction at the classroom level. It might include social skills in small groups. It could include social emotional learning booster sessions. So maybe you universally have something in place at your school and you're doing some booster sessions for kids who need something more. Check in, check out, right? One of the most common tier 2 interventions out there. Group counseling, behavior intervention plans, student mentoring programs, or peer mentoring programs, and then teacher-family consultation. All could be seen as mental health type supports that we're putting into place in our schools. And then intensive school and community supports. So this, again, tends to be when we think about mental health, I think what comes to front of mind. Individual counseling, functional behavioral assessments, and behavior intervention plans. Some of those are done at tier 2. Special ed consideration, behavior goals or mental health goals as part of an IE plan or IEP, or as part of minutes. Thinking about family therapy and counseling, wraparound services, community mental health, and then intensive small group or individual counseling. Okay, so how many services or supports do you see reflected in your own school or district as you look at these lists? So would ask you all just to type in. That's awesome. Thank you, Carrie. So Carrie had 23. For others to type in how many there may be seeing put in place. Okay, I saw 8, 22, 12, lots of numbers coming in terms of what they have in place. Yeah, most of them. So I'm happy to hear in Pennsylvania, we have lots of different strengths in our systems and ways that we're engaged in meeting the needs of students in our schools. So thank you for sharing that. That's great. So I see anywhere from like 80 to over 20, or 8 to over 20, not 8, 80. Maybe we're not that high quite yet. But certainly it's important to recognize that our ratios, right? The number of students that we serve impact the kinds of services we can provide. We published an article, I want to say it was 5 or 6 years ago at this point, that showed a direct correlation between once school psychologist to student ratios go up, the number of hours we're providing mental health services goes down, right? And the types of services we can provide is really limited. So certainly thinking about ways that we want to address the mental health needs. The last, when I was a school social worker, myself and our school psychologist, we served a high school of 1,700 students, right? There was 2 of us, that was it. And so we had limitations. We worked with 4 amazing school counselors, but we had limitations in terms of the kinds of mental health services that we had time to provide. Certainly, if you graduated in the last 10 years, that might look different than the kind of training program you attended 20 to 25 years ago, and your professional competencies that you received as a counselor, social worker, psychologist might look different in terms of what mental health services you were trained to provide. And so that really calls on our field to help our practitioners continue to develop their skills to be able to feel like they can be effective in delivering mental health services as well. So I'm glad many of you are here today. Hopefully even those of you who have received some training in Tier 3 mental health supports or even Tier 2 mental health supports will learn something new to add to your toolbox today. And then climate and culture can impact the provision of mental and behavioral health services that you can provide. There certainly is still a huge stigma in our country around mental health. And in many communities, there might be hesitation to sign a consent form to let a child participate, to run mental health groups. One of the one of the interesting stories I like to share is when I first moved to Madison 8 years ago, we were in a school district, not Madison schools, but a different school district. And we went out to talk to them about engaging in a project with us on universal screening. And we met with some of their district leaders, and they said to us, you know, we're really interested in universal screening for mental health, but we have a superintendent who's about to retire, and this person doesn't really see a place for mental health in schools. They think they really believe kids come to school to learn, that the focus needs to be on academics. And so we're going to need to wait till this person retires until we could roll something out more universally on screening for mental health. We were like, okay, we totally understand, you know, it was nice to meet you, we'll stay in touch. The very next day, somebody who was at that meeting called and said, hey, I found this screener for social emotional learning. It's an SEL screener. Have you heard of the SABERS, the Social, Academic, and Emotional Behavior Risk Screener? And I was like, wow, that's the exact measure we were out talking to you about the day before, but because we were referring to it in terms of mental health and social emotional behavioral functioning, not SEL, it landed differently, right? That school district saw it in a different fashion and were more hesitant to engage in it. But once they saw it as an SEL screener, right, they certainly had a different perspective on if it was something that they could adopt or use. So thinking about climate and culture in your initiatives and thinking about what phrases and terminology you use is important. Our friends in Florida, right, share with us that they no longer can say social emotional, and so they refer to a lot of their work as resilience. Important to be mindful of that too. Okay, so when we think about ways that we identify students who have mental health concerns, if we were in person, I would call on you to ask, how do students come to your attention? If you're thinking about students who have mental health needs, how do you find out about them? And usually the number one reason that folks will share is teacher referral, right? A teacher says, hey, I'm having difficulty with a student in the classroom, or I'm seeing these behaviors. Can you, school counselor, can you, school social worker, maybe come and take a look or talk with me about what I should do? We also see schools have problem-solving teams, right? Hopefully you work in a school that has a formal team set up, and there's a process by which teachers can refer or parents can say, you know, I'm concerned about my child. What kinds of supports are available at school for them? And you can use data to make some of those decisions. When I was working in the schools, I once received a slip from a pediatrician. A parent had gone to their pediatrician and was concerned about ADHD in their child. And the pediatrician wrote a slip and said, please give this child a 504 plan. Right? It was like a script for a prescription. It was like a prescription for a 504 plan. I was like, oh, this is new. Okay. And so certainly there's lots of ways that we find out about mental health needs and need to make decisions about how we're going to move forward. Teacher referral is the number one way as school mental health providers that we find out about kids. We've referred for a long time or relied for a long time on refer, test, place models. So thinking about how that referral comes in, how do we assess and provide information on what to do with this student, and then determine what type of interventions or placements are going to be most appropriate. The difficulties with sole reliance on this model is that teachers really differ in their ability to work with students, right? I think about 2 kindergarten classrooms that I supported in an elementary school. One teacher, both were seasoned teachers that had been teaching for over 20 years. One teacher had the mentality that, this is the first time that many of these kids are coming into school. They haven't had experience with reading. They haven't had experience with the school structure and environment. It's my job to be the ambassador to school, right? To teach them everything that they know. The teacher would occasionally reach out to myself or the school counselor. I was a school psych at this school, and ask us questions. But she had the mentality more of like, I'm going to take care of my own, right? It's my job to get these kids to where they need to be by the end of the school year. The teacher next to her, I kind of joke, right, that referred like half of her kids for an evaluation before the end of the school year, right? It was different. She wanted help and support. She had ideas about what the kids needed. And so that doesn't mean one teacher was right and one teacher was wrong. It just exemplifies that teachers have differences in the kinds of students that they can connect with, the types of services that they might need, and when and why and how I'm going to ask somebody outside of my classroom to come and help best meet those needs. And so many of our teachers don't receive training to know how problematic a behavior or concern must be prior to referral. And so we have a large gap between how long it might take a student to exhibit a problem and then for those actual problems to be referred. A more recent study suggests that academic concerns from when a student demonstrates those concerns to when they receive help and support is about 1 to 2 years from on average of when kids are going to get help, which still, right, can be concerning that there's those lags in delays. But for behavioral and mental health concerns, from when a student starts to demonstrate concerns to when they might receive some formal support is 5 to 7 years later. And so certainly makes a good case for why we need to provide some additional supports or make some changes in how do we screen or identify students for services. So ways that we might do that, right? And this is just some humor for us this afternoon. So when we think about screening for students who might be at risk or demonstrating early concerns, right? We want to think about those students who are showing emerging concerns. If we can have do a quick temperature check, right? Think about, right, is there anything that's raising to a level which we might need to be concerned or gather more information? And potentially at that point, gather additional information to let us know how to proceed. And so universal screening, right, might be one potential solution. Universal screening is meant to guide decision making within NTSS framework, and again moves from reactive to more proactive and preventative. It hopefully enhances equity in how we're identifying students and giving them access to services, and maybe a way that we can start to streamline our resources. And much of our research on screening has also shown that it can reduce mental health difficulties among youth when we're engaging in effective screening models over time. So I would just be curious, for those of you who are on the call, I have just a brief poll. If you could either use this QR code to scan with your phone, it should pull up the poll, or you can type in this website as well. So this is pollev.com, Katie Eklund. I'm going to put it in the chat here too for you. So if you just want to click on this should take you to it. If you just click on that link, and that'll let you indicate, does your school screen for behavioral or mental health concerns? How do you identify which students have concerns or need mental or behavioral health supports? So again, you might say we don't do anything, which is totally fine. We have a somewhat structured process. We use existing data, or we have a very structured process and we use a formal behavior screening to screen most or all students. So, okay, poll is full. So they're probably, I'm going to stop sharing this to pull up our poll. So just give me a second. And we'll take a look at what this looks like. So what I see is most of you have some type of structured process, and about 52%, and then about a quarter have very structured, and then a quarter no structured process. And if you didn't get a chance to, I'm just trying to clear that. Oh, great. Say if you didn't get a chance, I was going to let you enter your ratings, but it looks like they're down for maintenance, so we will not do that. For those of you who are engaged in screening, would you be able to share what type of screening measure that you are using? I see DESA, SRSS, BESS, SABRS, BESS, so lots of different, the BIMAS. Great, tons of different measures out there. Fantastic. All right, let me pull these slides back up. Great. Would folks be willing to share, those of you who are doing screening, can you talk about any difficulties or challenges that you have with screening? Any kind of existing screeners that, existing challenges that come up with the universal screening process at your school, if you're willing to share. I'll give folks a minute to do that. Great, thanks, Lisa. So staff understanding how to interpret the data, students completing with fidelity, potential subject to bias, objectivity of questions, inconsistency in responses, inconsistent implementation. Yes, being able to provide interventions to all the students who are at risk. People focus on the negative. Yeah. Fidelity. Fantastic. Well, those of you who are, again, this is not the primary focus of our presentation. We could do 3 hours probably on universal screening today, but I'm just going to touch, provide just maybe 4 or 5 slides here on universal screening for those of you who it's new for, and then hopefully address some of the challenges or address some ideas of ways to overcome some of the difficulties that folks have had with screening. And I'll kind of keep an eye on the chat. This is just some of the evidence for universal screening. When we talk about screening, again, we're hopefully using a brief behavior rating scale that helps us identify students who are at risk for social, emotional, or behavioral concerns. We might be screening all kids in a classroom, all kids in a grade, all kids in a school. Some people, when they, some schools, when they initially try it out, might start at 1 grade level as a pilot to see how it goes before implementing it universally across a school. Our local school district here in Madison, they universally screen all 6th graders, and then they screen again in 9th grade. So at the beginning of middle school and the beginning of high school is what they have elected to focus on. And they use that data to help kids go into different types of interventions. There's also questions about how often to screen. So is it best to do it once a year? Is it best to do it twice a year or 3 times a year? I think you should do it at however many times you have capacity for, certainly not more than 3. I don't think there's a need for it. But if it's new to your school, starting with once is a great idea, and potentially twice a year. So you're capturing students who maybe weren't present during that first administration. In the fall, making sure that you have long enough to get to know the students before you engage in screening. Recommendations at the elementary level really focus on teachers as the primary informant of ratings. So because we have some challenges with reading levels, sometimes in the developmental level of students, understanding what the questions are asking, teachers can be a good informant. And then as we get into middle school and high school, really focusing on students as being the primary informant. Students are usually research shows students are very accurate informants of their own mental health, their own social, emotional, and behavioral functioning. So that can be helpful for them to provide feedback on how they're doing as well. When talking about messaging, right, I gave the example of the superintendent earlier, and thinking about what are you calling this? How are we presenting screening data? Not all screening measures are created equally. They all assess different types of things. So making sure that you're selecting a screener that's actually giving you data to help guide what you want for your school. I think it could be helpful too to frame screening within the context of other assessment data that you're collecting at your school. So, our school screens for any barriers to learning, including vision, hearing, academics, and behavior. And that our focus is on addressing the behavioral and academic needs of all of our students. So making sure that that comes up. Parental consent is often a question that comes up, is do we have to get their consent on behavior screening from parents? This is guidance from the Wisconsin Department of Public Instruction, which is our Department of Ed here in the state. They put out this guidance long before I moved here. But their focus is that if we're gathering data from classroom teachers on existing classroom practices, so if we're using measures that were created for schools, so thinking about things like the BASC-3 BESS, the Behavioral and Emotional Screening System, or the SABRS, the Social Academic Emotional Behavior Risk Screener, that their sense is that that does not require parental consent because it's part of typical educational practices where teachers are rating students on school-wide behaviors. This goes on, and this is a very text-heavy slide, but I wanted to give you all of the language that they include. This answers the question around what if students are completing the measure. And it touches on PPRA, the Protection of Pupil Rights Amendment, which comes up a lot in screening. And again, depending upon the screener that you're using, it may or may not meet this criteria. But their guidance is really if a school district requires a student to participate, then active consent must be obtained. If you do not require students to participate, right, you're not incentivizing them, they are given the opportunity to opt out, then you can use passive consent rather than active consent. So certainly I'd encourage you all, as you're going down this process, to consult your local state laws and school district attorneys in terms of what would be allowed in your district, but at least wanted to provide some state level guidance that Wisconsin put out that's been helpful for our school districts in trying to navigate the consent form as well. Great, and some good conversations happening in the chat regarding what people are using and how they're using that. But just as some parting words on screening, if this is something that you've done or that you've been thinking about doing, certainly we want to use screeners that hopefully are brief in nature, right? Preferably that don't cost a lot of money and hopefully take a couple of minutes per student. That they are representative of multiple domains of student functioning. So thinking about both social concerns, maybe externalizing and internalizing concerns, as well as strengths and weaknesses. Research suggests we can best predict future behavior by thinking about both mental health concerns as well as, again, we're thinking about strengths and resilience and well-being as well. And so thinking about both concerns as well as aspects of well-being, and that they're psychometrically sound, right? Certainly as school psychologists, we think about aspects of reliability and validity, but within universal screening, it's important to also look at diagnostic accuracy. So that looks at things like sensitivity and specificity. We want to be able to accurately identify students who are truly at risk, as well as accurately identify students who are not at risk. And so when we think about sensitivity and specificity, we would want those rates to be at 0.7 or above in screening. So thinking about that as well. I certainly am not here to endorse a particular measure, but I wanted to provide a couple ideas of if you're interested in screening and thinking about the mental health needs of your students, right? How do we gather some of that initial data? These are a couple measures that are out there that have a lot of evidence to support their use in schools. The red lettering that's here gives you an indication of teacher, parent, or student forms that are available for each of the measures. So you can see the T along most of these would indicate there are teacher forms for teachers to provide ratings. Parent ratings are only available for the BESS and the SDQ on this list, and then student ratings would be available on the BESS, the SABRS, the Social Emotional Health Survey, and the SDQ. So again, just gives you a place to start, maybe a potential list to investigate if universal screening is something that you've maybe thought about before. Great. So the other question that often comes up around screening is, what if I screen all my students and I identify over 30% of students and we don't have those resources available to provide services at my school, which is, I think, a question you should be able to answer before you would ever administer a universal screener, right? You want to make sure that you have, that you know what you're going to do with the data and have necessary steps in place to address those student concerns. So this is a potential model to start to think about how you would use that universal screening data. I like to give the analogy similar to if you were to give an oral reading fluency measure to a classroom of second grade students, right? And you found that 15 of the 25 kids in the class were below grade level in reading. You're probably not going to pull out 15 kids individually for reading support, right? You're going to think about classroom-wide, what can we do to provide some reading support for those students? Or how can we push in small group support for those 15 kids who need some additional reading services? I would really encourage you to think about your universal screening data in a similar fashion. If you have over 20% of the kids at school, base rates is a fancy way of talking about prevalence rates. Amanda Vanderheyden talks about this a lot with some of the academic screening data as well. If you have base rates over 20%, what do your system-wide supports look like, right? What do tier 1 supports look like for supporting universal interventions at school? And that might look like, if those supports are over 20% for social behaviors, that might go back to PBIS to think about, what are we doing to teach school-wide expectations of behavior? How do we reinforce some of those things in the classroom? If you administer screeners and you have a preponderance, a high percentage of students in a particular classroom, right? Over 20% of kids in a classroom. Let's say you use something like the SABRS. The SABRS gives an overall indication of risk, but it also can show you social behaviors, right? Or emotional behaviors. Emotional behaviors really speak to internalizing behavior concerns. Then that might be something, if we have a classroom where over 20% of the kids have internalizing behavior concerns, we might look to plug in like a social emotional learning intervention or curriculum in that classroom to be able to address some of those concerns. And then finally, last but not least, right, we're moving to individual and small group support. And these don't have to be necessarily cut scores. This doesn't mean kids who need individual or small group support won't get them until these rates are met. That's certainly not the suggestion here. But the suggestion is really to think more systemically about how to use your universal screening data of what it's telling you about your population, and thinking about some of those population-based considerations of what all kids need, what kids in certain classrooms need, versus maybe going through a list of 60 to 80 students who came back as at risk and only thinking about individual or small group supports for those students. So just some additional considerations here. Again, using data to guide what you're going to do to help support them, and hopefully not anytime a student has a need that we're jumping from tier 1 to tier 3 in the mental health supports that we're providing for those students. There are some limits, right, with screening data. Again, screening's not diagnostic. It's not here to tell us, does the student have depression? Does the student have a conduct disorder? Does the student have anxiety? It's really a red flag indicator or a temperature check saying, here's a student who has this need. And thinking about different types of decisions we might need to make. So universal and tier 2 interventions, again, should be our first considerations in the identification of initial needs and gathering additional data to say, do we think that this is severe or significant enough to warrant tier 2 or tier 3 intervention decisions. Some questions came up in the chat around equity, right, and bias in screening. And certainly that's been one of the larger considerations in our teacher screeners, is making sure that we have high quality information. The quality of information certainly in a system is directly related to the data produced and decisions that follow. My colleague, Dr. Von der Emps, talks about, trash data in as trash data out. How we are, what decisions we're making, we want it to be based on evidence-based data and valid assessment measures. And so making sure that those are what are guiding our decision making. We want to also train raters, educators, and students on the content and purpose of screening or other assessments that we're using, including implicit bias, right? Are we sharing data? Are we telling students, we're having you fill out the measure, here's what we're going to do with it, here's the decisions that this will guide, so that students understand why they're filling out a rating scale and what kinds of decisions will follow after that rating scale has been implemented. And then also thinking about, how do we disaggregate data, right? Are we looking at percentages of risk in a particular classroom? Are we disaggregating that data by student demographic considerations? So certainly we want to think about the consideration of cultural mismatch between students and teachers, and other sources of data following an at-risk rating. We might have a teacher who's rated a student at risk, but this is a student who has great attendance, their grades look fantastic, they don't have office discipline referral data. We might be meeting with them and learning, about lots of strengths that they have, things that are going well. We're going to need to get some more information from the teacher to understand, why is what the teacher's saying not aligning maybe with every other source of data that we have to suggest that this student actually is doing well. And then thinking about, how can we also calculate risk ratios to evaluate screening results based on race, ethnicity, and or gender. One of the ways schools can provide feedback is to give teachers their data back using those disaggregated scores. We know that individuals are internally motivated to act in a non-biased manner after they're shown the results of previous behavior. I don't know any teacher that wants to provide bias ratings, right? Or wants to continue to engage in behaviors that might be harmful to students. And so certainly we want to give that screening data back and talk about why we might see discrepancies in maybe a disproportionate number of students being identified as demonstrating risk. Why might that be happening? What can we do to help provide some psychoeducation to the teachers in our school? What can we do? What can we do to make sure that we're getting accurate and equitable results? And then also providing both teacher and caregiver training on mental health literacy. Certainly there's been multiple studies that have talked about teachers and parents wanting to know more about mental health literacy and how to support students who are starting to have some of these early challenges as well. So our smhcollaborative.org has, we just put out a new version of the Universal Screening Implementation Guide. If you're interested in learning more, that just got released this spring. And so that can be accessed at this website if you're looking for new ways to implement screening or ways maybe to improve strategies you've been using at your school for screening as well. All right, before we move on, any other questions that folks have? That people are making connections here and okay, otherwise we're going to dive into interventions here for the rest of our time together. Okay, so tiered mental health interventions and support. I'm going to touch just briefly on some ideas around universal and tier 2, not long, and then we'll spend more time in tier 3. But universally gave some ideas at the beginning of a variety of mental health strategies that you might consider. Certainly having positive school climate is important at your school. We want to think about, I think about kind of these 4 pillars within climate in terms of things like social and emotional support at school, that there's caring, respectful, and reciprocal relationships between students, staff, and families. Do we see student engagement, right? Are students engaged in learning and in the school environment? Do we see structure, right? So high behavior expectations, equitable disciplinary practices at school, and then finally safety and belonging. Do students and staff feel safe, connected, and included at school? Many of the mental health interventions that we might consider implementing, if students don't feel safe to come to school, right, and aren't present, it's going to be really hard for us to deliver some tier 3 services. So certainly we want to start at tier 1 to think about what do those relationships look like for students in feeling safe to be at school as well. The last session that you had, you talked about the interconnected systems framework. So Kelly was here and presented on lots of ways that you might be able to integrate multi-tiered systems of support and to align that with PBIS systems. So would encourage you to go back and check out that 3rd session if you're interested in learning more about that. Mental health literacy is another universal support, so ensuring staff, students, and families know why mental health is important and how to refer students who need additional support. And then finally, universal social emotional learning programs. What might we be able to implement universally in classrooms and grades and schools to support students' social emotional learning at that universal level is important too. I also want to highlight that foundationally, we're going to spend time talking about different evidence-based interventions here, but that therapeutic relationship that you have with a student has been found to account for approximately 30% of client change. right? Establishing trust and rapport, building that effective relationship with a student is I would say, is equally, if not more important than the implementation of any evidence-based intervention. Making sure that we establish unconditional positive regard with our students, that they understand how and why we care about them and their well-being is essential for us being effective in implementing those evidence-based interventions. So prior to diving into tier 2 and tier 3, just wanted to spend a minute talking about, that you'll need to develop, and certainly again, we can spend some time. We could do a whole other session talking about that therapeutic relationship, but want to emphasize the need for you all to work on building those positive relationships with students, which I'm sure so many of you do. Because without that, many of our evidence-based interventions won't be as effective as they can be to lead to that student growth and change over time. So important to keep that in mind. Okay, so wanted to provide a list of tier 2 internalizing interventions that are available. These are a couple evidence-based interventions that are out there that address the internalizing needs of students. We're going to talk today about Coping Cat as a tier 3 intervention, and I'll provide some more details about that. But there's also a brief Coping Cat that's shorter in nature. Ken Merrill, who's out of the University of Oregon, about 20 years ago, released Strong Kids, Strong Teens program. It is a manualized intervention program that you can purchase. It's maybe $30 to $40. The book's pretty inexpensive, but a manualized curriculum that can be used both universally and at the tier 2 level. They have Strong Start for preschool. Strong Kids is the elementary level, and then Strong Kids is for secondary students. We've used that a lot with our graduate students and in their practicum placements to help lead small group interventions, which has been really effective. We've also adapted it and used it in a juvenile detention facility here with adolescents and had a lot of success with that as well. So I'd encourage you to check that out. I'm going to spend a couple minutes talking about the Resilience Education Program, which is a tier 2 intervention that we developed here at UW-Madison. Calm Cat, Brittany Zakzeski, who's at the University of Delaware, created a similar version to REP, but for for younger learners. So it's like kindergarten through 2nd grade. Yeah, Dr. Z is the best. Brittany's program is fantastic and is a nice resource for kids in primary grades, teaching them good coping and problem-solving skills. The Courage and Confidence Mentoring Program is part of Clay Cook's work out of the university when he was at the University of Minnesota, and they have a couple studies on that as a tier 2 intervention. And then certainly some adaptations for check and check out have been made for internalizing behaviors. That includes ways to use check and check out with a peer mentor. I have a graduate student who just finished her dissertation using, we were using REP, which I'll talk about in a minute, we had groups of 4th grade students who were participating in a tier 2 intervention, which is paired with a modified version of REP. And instead of having adult mentors for check and check out, they had 5th grade students serve as peer mentors. And the 5th graders would go and do the check-in in the morning with the students. They would go over the goal sheet for the day, and then they would go and do the checkout at the end of the day. And it was really cool to watch. I got to go and observe the students. And it went so well that at the end of the group, the 4th graders were asking, do I get to be the mentor next year in 5th grade, right? Like they wanted to step into that leadership role. So there's lots of ways, hopefully, that can also sustain its growth and development and lead to some really nice leadership skills over time. Other tier 2 interventions for more externalizing behavior concerns. Check and check out is one. Social skills instruction, so small group social skills, which many of you are probably already engaged in. Check, connect, and expect. A daily report card, right? And there's some references here if you're interested in learning more about these. Russell Barkley does a lot of these with students who have ADHD and thinking about how do we help students maintain attention to task, whether at school, and connect parents as part of this intervention. The class pass intervention, breaks are better. Behavior contracts are another one. And then coping power, which I've seen delivered both at tier 2 and tier 3. And we'll go into coping power a little bit more when we get into our tier 3 interventions today. So I'll walk you through that. Just trying to be mindful of time here. One last tier 2 intervention I want to highlight is the Resilience Education Program. There's 3 of us here at UW-Madison that have been involved in developing this program over the last 9 years. And REP is a 3-part intervention designed to support students who are showing early signs of, or those subthreshold symptoms of internalizing behavior concerns. Our hope is that we can teach students through a brief intervention coping and problem solving skills as a way to hopefully decrease rates of more significant diagnosable internalizing concerns of students as they progress. So REP is targeted for students in grades 4 through 8. We have about 9 studies published to date on the effectiveness of REP in decreasing students' internalizing concerns and hopefully increasing, or we've demonstrated that it does increase academic engagement and social engagement at school and at home. We are in the process of developing a high school curriculum as well, which we're currently pilot testing, and that should be available in another year. But REP is 3 components. It starts with a small group instruction. We call it cognitive behavioral instruction because it's tier 2. There are therapeutic components to it, but it's only 5 weeks in length. It's a small group format of 3 to 5 students because we're working with students who have internalizing behavior concerns. Our hope is that we can more actively engage them in the group process and address their specific needs so they can get the most as possible, right? We found when we have too many kids in the group, some of them tend to sit back and not be as actively engaged and are more quiet by nature. And so we've kept the group small, and because it's short, if you have a need for more students, right, it's 5 weeks in length, you can run a second group after the first group is done. But the group is focused on helping kids develop coping skills. We do activities like cognitive restructuring, and then helping students walk through a problem-solving model and developing some of those problem-solving skills. We pair that cognitive behavioral instruction with a modified check-in, check-out tier 2 intervention. So similar to standard check-in and check-out with a mentor each day. We want the students basically to take the skills they're learning in group, and we're hopefully promoting generalization and maintenance of those skills at school and at home. REP is targeted right now on students in grades 4 through 8. I saw the age level question come up. And then we're in the process of developing a high school curriculum. So that hopefully answers that question. The check in, check out piece, I'll show you here in a second as well. But then the third component is resilient families. This is a parent training on key skills and how to support, again, both what kids are learning in the group and check in, check out at home. So the focus on the small group is that it's student oriented. We're thinking about how does the student function at school and at home and in their larger community. And again, taking the skills they're learning in group, that it's ecologically oriented. We want to know how does that interface, how are they using those skills in the real world? And so we're prompting and reinforcing the student use of those skills in other settings. Our theory of change with this cognitive behavioral instruction, and you'll see this when we start to talk about cognitive behavioral therapy within Tier 2, is this connection between thoughts, feelings, and behavior, right? This triad that we see in CBT, that there's a strong connection for all of us, and how do our thoughts guide our behaviors, which guide our feelings. Oftentimes behaviors guiding feelings, feelings guiding thoughts, and this circular nature of how our behavior and emotions play out. Within REP, what we see is for many students, triggers for their behavior can be things like having teachers ask for volunteers in a classroom. For a student who has anxiety or who's maybe more withdrawn, they might know the answer to the question, but they're worried. Their automatic thought is, I'll forget what I was going to say. And so they put their hand down, they don't speak up in class, and they might have feelings of worry or embarrassment. The goal with REP, using kind of the CBT model, is to help students have more helpful thoughts, to be able to say, I can do this, I know the answer, and to learn things like their STU skills. So we walk through, see the trigger, take a breath, and use your imagination. So we walk through things like deep breathing or belly breaths and using positive imagery to help students be able to calm down, to be able to center themselves, to do some cognitive restructuring when they're engaging in actions and feelings that might not help them be and engage in the behaviors they need to be as successful at school as we hope they would be. So the timeline of this Tier 2 intervention focuses on the small group intervention that starts at the same time as Check In, Check Out and Resilient Families. And they all go for 5 weeks. When the group ends after 5 weeks, the hope is that the modified Check In, Check Out and Resilient Families will last an additional 5 weeks to continue to promote that maintenance and generalization of the skills that the kids learned in the group. So they'll still be meeting with their mentor, will still be connected with families to talk about how kids are using those skills. These are the 5 lessons that are a part of REP. So REP is designed to be taught once a week for about 45 minutes to an hour, or it can be broken down to be twice a week for 30 minutes. And we talk about things like team building and introduction, identifying strong feelings and what are those triggers for strong feelings. How do we use coping skills to manage the emotions that we experience? How do we use cognitive restructuring? What does that look like? Giving students, it uses an say, show, do model, right, of direct instruction, or an I do, we do, you do. And then using problem solving strategies, having students are walking through a problem solving model that students can use in their own life as well. The check in, check out process or procedures for REP, this is typical check in, check out that students might be engaged in. And then the modified components include modified DPR targets, which I'll show you here in a second. Oh, those aren't coming up. I'm not sure why. There's skills aligned with CBI. Other positive behaviors, and then students self-rate their mood throughout the day. I want to see if I can find, let me stop sharing this for just a second. I want to see if I can share, this might do it, the modified DPR, because I think once, let's continue to share. Nope, it looks like it didn't save it. The modified check-in or DPR shows what those modified DPR targets look like, but I can pull that up when we take a break as well if you're interested in seeing that modified form. So we change the kinds of things. Usually the daily progress report on standard check-in, check-out includes things that are like the school-wide behavior expectations. we've changed those to include things like controlled emotions and made good choices. And then the third behavior that we have teachers rate is something that's specific to each student. And then they rate themselves on a scale of 0 to 7 each day on how they did on those behaviors as well. So a little bit different, but has a modified version as well. You know what? I bet it's going to come up now. There it is. So here's controlled emotions, make good choices, and then that third one is open, and then this is what the how I felt scale looks like. Much easier to see it than for me to explain it to you. But that's what the modified components look like. And again, more of a focus on, again, the internalizing behaviors. We also usually change it up and we don't always have like the teacher rate a student 4 times a day, or to have in the secondary setting 4 classroom different teachers rate. We might pick one teacher in the morning that the student feels comfortable with, and one teacher in the afternoon for our middle school students. And then in an elementary classroom, we might just pick one time in the morning and one time in the afternoon. Because again, it's different than externalizing behavior where we're trying to catch students doing good, right? We're trying to provide that positive reinforcement. In this case, that relationship the student has with the adult is really important, and that they're helping provide that positive reinforcement of when they're using some of these skills in the classroom too. So some variations on standard check-in, check-out. Okay, I want to explain this last component of REP, and then we're going to take a break because y'all been sitting here for a long time. Resilient families within REP. This piece, and our REP training is usually a full day, so I'm trying to teach you this in like 10 minutes. So I apologize if I'm going super fast, but I at least want to give you a snapshot of this as a potential tier 2 intervention. Resilient Families starts with an initial collaborative meeting that we have with parents before REP starts. It's typically the school mental health provider who's leading the small groups that meets with parents to talk about, here's a group we'd like your child to participate in, here's why, and for us to get some more information about how do things look at home. When we certainly have a lot of information about your child and how they're doing at school. What are your hopes, dreams, and wishes for your child, and how are they doing with these things at home? Because sometimes, right, kids present differently in a home setting than they do at school. Our hope is to be able to link some of that REP intervention to the goals that parents have, and to find ways that we can keep parents engaged. While we implement the 5-week intervention, we offer times to meet with families to provide a goal-directed brief session with them based on what their needs are, but it's not required. It's really guided by what families' wishes are and how to best support their child with internalizing behavior concerns. And then at the end of REP, during the 5 weeks the child's participating, we have an email that we've created that goes out to parents and teachers about what kids are learning in group. Parents can provide, feedback on what they're seeing at home. It gives ideas on things that parents can work on with their kids while they're participating in REP. And then at the end of that time, we hopefully connect with parents again. That might be in person, it might be over Zoom, might be over a phone call, to talk about how did it go. And then to really, because this is a tier 2 intervention, to make some decisions around, do we find that the student needs something more? Do we need a more intensive tier 3 intervention, like some of the ones we're about to talk about? Or do we need to, does it seem like the student's doing really well and we just want to have some regular check-ins to see how they're doing after this time? One of the most common things we hear back, with students who've participated in REP, at the end, one of the most common requests students have is they want to keep meeting with their mentor as part of check-in, check-out. They really like the positive relationship that they've established with the mentor. So sometimes even after the REP group ends, that piece will continue for an additional couple weeks, or maybe will happen a couple times each week, depending upon the school's capacity to support it. But because, again, we're talking about a tier 2 intervention, certainly make decisions about, do we need to increase the intensity of an intervention, or is this going to is this going to be enough for the student? So REP has been developed with the support of grant from the Institute of Education Sciences. That's the research arm of the Department of Ed. As a result, we continue to keep it available for free, which is fantastic. So you can access this intervention either through the QR code or through this website here, and find it has an intervention manual, it has student handouts, it has everything you need to implement, including access to slides and other parent handouts. So yeah, there's a question, is there training available for coaches? Train the trainer. Yeah, we do a full day training on REP, which would allow you to take it back and use it. And it also is considered kind of our train the trainer model, that you could then take it and also provide a briefer training to others in your district who might want to use that as well. Okay.
There were also just a couple questions
Sure.
with REP. So could you just clarify the age or the grade level that it was developed for or appropriate for?
Sure. So I'm going to just stop sharing. REP is developed for students in grades 4 through 8. So it's meant for upper elementary and middle school students. And we're in the process of developing a high school curriculum. I will say I have had school mental health folks tell me they've taken the middle school curriculum and delivered it at high school and have really liked it, but we just haven't evaluated or tested it in that capacity. And we're trying to create more kind of age appropriate examples and video links and things like that in the high school curriculum. So we anticipate it'll change a bit, but right now 4 through 8 with high school to come.
Okay, great. And then there was a question related to the mentor. Would that be the same person that does the groups or that conducts the groups?
It doesn't have to be. I think in some schools that's what's worked well. In other schools, it's been, similar to other check and check out models. It's been an elective teacher, it's been a paraprofessional, it's been somebody who works in the office, maybe a peer mentor, but certainly there's some flexibility in who that might be.
Okay. I think that's everything that was in the chat thus far. Here's one more from Lily.
Yeah.
Are you
The
considering
younger
adapting the
students,
program for
yeah.
younger students?
Yeah, or
Yeah,
even like second, third, I was thinking.
yeah, good question. Um, We, I think because the focus of the curriculum has been on cognitive behavioral it's asking kids to think about their thinking. And so it requires some more advanced thought, right? And so that's been the challenge of thinking about how do we develop this with younger kids. One of the intervention programs I might point you to that's taken REP and developed it for younger learners is when I was talking about Brittany Zakzeski's program earlier. That might be, and that's Calm Cat is her intervention. Brittany's at the University of Delaware in their school psych. She's faculty in their school psych program, but she's had some great outcomes with the Calm Cat program, which is very similar format to REP, but it's I want to say K2. There you go. Thanks, Lindsay. Yeah, but she has younger kids that I know it works great with as well. All right, and then I'll just point everybody before we jump in to talk about Tier 3 intensive mental health supports. Bryn has put the resources that we've highlighted today are in the Padlet. So if you're interested in the slides or anything else that we've discussed, you can look at the chat and there's a link in there. So thank you, Bryn, for doing that. That's super helpful. All right, so there are lots of different Tier 3 interventions that are available. What I tried to highlight for the purposes of today are those that would be Tier 3 interventions that would be compatible for use in schools. Some of the challenges that we have with tier 3 or more intensive mental health interventions just have to do with their transferability and usability in school settings. And so as I was pulling resources together for today and considering what to share with you, that was really on front of mind for me, is thinking about when I'm in a school and I'm thinking about what types of resources that I want to implement, or the types of groups or individual supports I'm providing, is what's going to be most effective given the limitations I have with the school calendar, with students coming to school, with space considerations. And so my hope is that by highlighting these 6 different tier 3 interventions today, that these would be ones that probably show they have not only a large evidence base to support their use in schools, but also might be feasible to implement within a semester of your school year, or across the school year that you're in. So certainly maybe starting these today on May 5th may not be feasible to get through the end of the school year, but certainly in doing some planning for the fall might help you be able to think about interventions you might begin to look into for implementation in the fall. Great, so let's dive in. Cognitive behavioral therapy is one of the most common treatments for a variety of concerns present for children within schools. It really focuses on the relationship, again, between our thoughts, our feelings, and our behaviors. And it's designed to be an evidence-based counseling or therapeutic treatment that focuses on altering maladaptive thoughts and beliefs. Research shows that it can be used to treat a variety of mood disorders, anxiety, depression, eating disorders, even externalizing behaviors and more. But it's seen to be an evidence-based shorter-term individual and group therapy that can last anywhere from 6 to 20 sessions, depending upon the type of intervention that you're using. In a cognitive behavioral therapy model, right, we're thinking about, again, that connection between thoughts, feelings, and behaviors. So in working with a student, for example, who might be experiencing depression, they might have the thought process of, nothing will ever change. I have low energy, I'm potentially unmotivated, I have feelings of hopelessness, and as a result of these feelings, I often stay in bed and I don't talk to anyone. Our hope with cognitive behavioral therapy is that we can start to, when we think about this triangle or this 3-legged stool, that we can make some potential change in thinking, feelings, and behavior to help children or adolescents start to feel like they can enjoy things, that we're leading to increased mood, helping kids develop feelings of mastery and hope through small changes in their behaviors. So that might be things like texting a friend to talk, or having a friend join for dinner. One of the things we'll talk a little bit about is behavioral activation, both in an individual or small group setting, that we're making some of these small highlights or small behavioral changes to students within their day, and that increase and boost based on these small behavioral changes can make subsequent changes to their thinking and feeling. So we'll walk through that in a little bit more detail here through an example of behavioral activation as one CBT strategy. Another tier 3 intervention that maybe many of you have seen or heard about is Coping Cat. Phil Kendall has done work on Coping Cat over, I want to say, the last 2 or 3 decades. It is designed to target children ages 7 to 17 years who are experiencing anxiety. It also is appropriate for children who are diagnosed with anxiety and depression, or maybe experiencing both types of concerns. Coping Cat focuses on psychoeducation, cognitive restructuring. It has aspects of somatic management plans. You think about kids who are maybe complaining that their stomach hurts or head hurts, or often down at the school nurse's office because the manifestation of anxiety has come out through physical symptoms in their body. And the intervention also works to develop, help kids develop gradual exposure to anxiety provoking situations. There are 16 weekly sessions of this intervention, so it's a little bit longer. The first 9 sessions, and I'm sorry, that should say sessions 1 through 9, not 1 through 0, focuses on skills training. So how do we work with kids to develop the skills that they need to effectively manage their anxiety? And then sessions 10 through 16, they practice those skills that they've learned in the first 9 sessions. The Coping Cat intervention uses this FEAR acronym. So feeling frightened is that F. It talks about awareness and uses relaxation training using modeling, role play, and practice. Expecting bad things to happen is the E in that acronym. So it talks about how faulty expectations that kids might have, it helps kids be able to identify what are those faulty expectations and to start to challenge those over time. There's cartoons in the Coping Cat workbook that help kids understand how this is happening with other animals and characters and individuals, and then provides the child with practice in identifying the thoughts of their own before they're expected to share those with others in that small group who are part of that intervention with them. The A, as part of that acronym, talks about attitudes and actions that might help. So it uses a problem-solving approach to help children develop confidence in taking action to meet some of those daily challenges, and with a focus on generating and evaluating alternative solutions to problems that they might be experiencing. The children are guided in that session, and they have their own workbook as part of this manual. So you can see their workbook here in how they use problem solving outside the session. So it gives them a chance to reflect and practice some of the skills that they've learned in group, outside of the group, and then to bring those back and be able to talk about that. And then finally, results and rewards. The approach behavior and approaching those things that might have been causing children anxiety is shaped and reinforced. So those avoidance and fear behaviors are reduced through things like self-monitoring and contingent reinforcement. The facilitator or counselor who's leading the group rewards partial success of the students who are participating and models coping strategies and uses role plays to demonstrate self-monitoring, self-rating, and self-reward. So the treatment manual, the parent workbook, and student workbooks are available. Thank you, Bryn, for putting that up here as well. But they just recently redesigned Coping Cat. It uses the same format. If you have the old manual, which I think came out maybe in 2008, 2010, 10 or 15 years ago, but now it has better graphics. I met with Dr. Kendall a couple months ago, and he was sharing that it just needed a refresh. So we had a graphic designer who offered to revamp the curriculum for him, which is great. And so if you've used the old version, it's the same curriculum, but it just has better graphics now, which is great. And so you can order those, or you can order the workbook to be able to use that in your practice as well. I've had experience implementing Coping Cat in school settings. We also use it in our university training clinic here with small groups of students, and have seen a lot of really good success. And again, just to go back, whoops, I went forward instead of back. Hold on. Sorry. We're thinking about elementary age students through high school students is the age group. But again, maybe not our kindergartner and first graders, but looking more at age 7 or 8 in terms of students that we want to start this intervention with. Okay, the next intervention, which uses principles of CBT, is behavioral activation. The theory behind behavioral activation, right, and promise in this intervention is what we see when kids are depressed is that they naturally withdraw from activities. So behavioral activation is really effective in treating kids who are struggling with depression. Behavioral activation targets withdrawal even if we see motivation is low in our students. So there's a belief that oftentimes with kids that they have to feel better before they can start doing things. But instead, behavioral activation really targets the behavior leg of that CBT triangle by changing behavior first and seeing how that can improve mood and feelings. And over time, what studies show, and those of you who are counselors who've used this and therapists, is that over time that can also improve children's thoughts. Its theory and focus on behavioral activation is that doing small things and small steps, right, is important. Waiting to feel better over time doesn't work. Instead, we're focusing on small changes to our behavior, which can lead to changes in thinking and mood. So behavioral activation really focuses on how do we schedule enjoyable, purposeful, and rewarding activities, or how do we help kids and work with parents to help their child schedule some of these enjoyable, purposeful, and rewarding activities to work to rebuild mastery and connection for students to return to previously enjoyed activities. So as we think about how this targets depression, right? With depression, we see that it can lead kids to experience reduced energy, fatigue, low motivation, and decreased pleasure. It doesn't exist in a vacuum. It's related to a lot of other things. We might have parents or teachers who are coming to us and saying things like, my kid, like a parent might say, my kid is lazy. They are sleeping a lot. They don't want to brush their teeth. I can't get them out of bed in the morning. They don't want to initiate or complete some type of task. Or maybe in the classroom, they have difficulties concentrating. Oftentimes that may be depression that hasn't been diagnosed, right? When we see lethargy or kids not enjoying previously enjoyed activities or a significant change in mood. We might have a kid who has low energy that takes a lot to do anything. They might not even want to send a text to their friends or engage in activities that they used to enjoy. So thinking about a kid who maybe enjoyed playing soccer or basketball before, and so they're laying around the house a lot or sleeping a lot and they're in their room. That certainly can lead to decreased feelings of happiness and pleasure. We might see kids experiencing more guilt, and so they're not seeing their friends and they're not wanting to go to school. Certainly that can cause a lot of challenges, but it may not at this point have been diagnosed as depression. We're just trying to find a way to re-engage these students. Our goal with behavioral activation is to interrupt that cycle. So thinking about how that maybe made them feel. So the idea that increased activity can lead to more productivity, less helplessness, improved mood or depression, and then hopefully increase energy and motivation. So thinking about, again, focusing on one of those legs of that CBT triangle can lead to changes over time. So behavioral activation has a longer established evidence base for adults with depression, but there is emerging research on it as a promising practice for children and youth. Two systematic reviews that were conducted found behavioral activation to be effective in treating depression in youth who are 8 to 18 years old compared to waitlist controls. So again, we're thinking about more of our third, fourth grade students through high school students. In many of these studies, these were individual sessions. There were a couple studies that had group implementation of behavioral activation, but many of them were employed in schools or community settings. And they were typically weekly individual sessions lasting anywhere from 30 to 60 minutes that were guided by a manualized treatment. So the Baker Center for Children and Families walks through this step-by-step guide of behavioral activation that I'm going to share with you just over the next couple of slides that helps counselors or therapists who are interested in using behavioral activation with clients think about how to help students engage or children engage in daily routines that start to build in structure again to work more on that behavior leg of that CBT triangle. So the first leg is activity mapping. So we're just going to walk through each of these steps. In the activity mapping is helping students look at what does their day look like now. So we might think about routines, structure, and when is that unstructured time coming into play. For many of those students, it might be after school, it might be at night, it might be on weekends, and these would be important times to think about how we might plug in behavioral activation for students and start to structure some of those times. A lot of behavioral, the activity mapping would then be working with kids to have them assess their mood ratings across the day. So we might do this through some type of feeling thermometer on a scale of 1 to 10. What do your activities look like throughout the day? When did you feel like, was it a 3 throughout the day? And then this one activity you engaged in, it felt maybe like a 6 or 7. But you're looking at possible open slots for possible activities and helping students rate their mood before and after engaging in those activities. When you see those open slots of time, we would then think about how we connect activities to the student's values. So if this is a student who just likes to have fun, there's a list of different activities there. If there is a student who we know wants to make connection with other kids, but has just kind of lost motivation potentially to do that, there's some ideas of the different kinds of activities we might plug in. If it's a kid who likes to have purpose in what they're doing or kindness, this is meant to be kind of a menu of activities. Somebody who has pride and mastery in what they do. This is meant to be a menu of activities, and you can pick and choose across categories, but obviously for every kid it's going to be different in terms of what might be best. But starting small and thinking about, maybe the evenings are difficult for me after dinner. And so I'm going to schedule 30 minutes to bake cookies with my parents on this one day. Or maybe after school, I have a lot of downtime, and that's when I really seem to fall down in this slump and have very low mood. And so art is something I enjoy. So for 30 minutes after school, I'm going to engage in an art project. And so it's time limited. It's meant to be very specific, but to help students start to feel a connection and to, again, look at those mood ratings before and after the activities. So when you schedule and do the activities, the goal is to choose a few concrete, realistic activities, to identify when and where they can fit in, and to think about small wins. So once a student would pick an activity they would feel comfortable about, you can think about where that would fit. You want to stay away from doing something that's more general. So instead of saying, when I get home from school, I'm going to spend time outside, I would think maybe about saying instead, I'm going to spend 10 minutes walking 3 blocks around my neighborhood, or I'm going to spend 15 minutes shooting hoops outside. It's meant to be small wins so that we're not setting ourselves up right for failure from the beginning. The focus is also on doing the activity, even if when kids don't feel great, right? The hope is that through some encouragement from you or from their parent, that they have enough motivation to get out there even when they don't feel like it. And then to be able to rate their mood before and after, and certainly to celebrate the effort. What can you do to provide verbal reinforcement, right? To encourage kids to get out and do this concrete activity and to reinforce what they've done and celebrate that effort after they've engaged in that. So certainly if we're working with parents to set up this kind of schedule or to help support a child in that, it can't certainly be up to a child to do this on their own. We would need to have parent buy-in and support. And so we'd want to talk with parents about the difficulties that they're experiencing, seeing their child be depressed or experiencing low mood. And so we want to give caregivers tools they can use. For many of the students, if a child wants to have a play date or they want to get together with someone else, parents are going to need to be able to help schedule that, right? So being able to help organize activities with a child or to communicate with other parents to get them together with another child. We also want to think about reasonable goals. So if you're working with a child, they might say, well, this Saturday, I'm going to clean my whole room. Well, if you have a child who has depression, that's a really big goal. That's something we might be setting them up for failure from day one. So maybe instead of saying, well, you're going to clean your whole room that maybe hasn't been touched in a couple of months, we might say, why don't we start with, hey, I'm going to do something smaller. If they're interested in cleaning, can I organize 3 drawers in my dresser so that they can have some of those small wins to set some reasonable goals. Then if they're successful in that, we can slowly scaffold some of those goals up if they're able to positively engage right in those activities. Or so thinking about what those small steps might look like as well. We may also have parents create an activity list and to be able to schedule and join the activities. For many of us, I'll say I have a 9-year-old daughter, and a lot of times I'm picking big things that we just want to go and do together. If you're working with kids who are maybe struggling to get out of the bed in the morning, struggling to change out of their pajamas for a couple of hours, you'll want to think about planning time to just be with the child. Maybe not times you're asking them a lot of questions or asking them to do anything. It might just be picking a time to go play a video game together, or maybe just to go for a walk. And so thinking about, that it can be difficult for kids who are experiencing depression to make decisions. So we really want to be able to focus on meeting them where they're at in that moment. I think it can also be helpful to work with parents on identifying strategies for praise, tailoring that to the developmental needs of the child or developmental level of the child. So verbal praise is great. I think an additional reward or physical reward can help reinforce that verbal praise to provide that extra boost, and then providing some ongoing monitoring and support of that as well. And then some of mood monitoring, right? If you're thinking about how we support, if we're looking at behavior ratings over the day or checking in on behavior over time, kids who are struggling with depression are prone with kind of all or nothing or that black and white thinking. So it's either was a horrible day or it was a great day, right? I'm never happy or I'm always happy. Our hope is that with some of the activity scheduling that we can see how kids might rate themselves before an activity, right? So most of my day may have been a 2 or a 3. I didn't feel like it was a great day, but the 30 minutes that I got to make cookies with my mom, or the 30 minutes I maybe got to go play a video game with my dad, maybe that was a 6 or a 7. And so then you can start to challenge those ratings to say, hey, right, if I go back and look at your day, we see an increased mood during these activities and evidence of when you actually may have felt better. And this also can increase a mood of expectancy and an understanding of when you can feel better, like those things that can challenge some of that all or nothing thinking, to highlight when were times that kids were actually feeling better. So if you look at a day when you were really struggling, right, again, we're mapping out those times of the day and we see lower ratings, those might be happening. Maybe it's at night before a student's or a child's going to bed. We want to think about what are activities we could put into place, like listening to music or being able to text a friend. Maybe that's when we're scheduling that time to help students, right? So again, the feelings thermometer that a student is providing those ratings can be helpful, as well as when parents are providing observations of behavior throughout the day as well. Okay, so that was a little bit of a deeper dive into behavioral activation, but maybe gives you some ideas of what that could look like in a counseling or therapeutic setting with a student. And there's some more manualized programs that walk through some of those steps as well. But that was one of the other interventions that I would mention or wanted to share. The next program we'll talk about is the Penn Resiliency Program. Y'all have a lot of great things coming out of Pennsylvania. This is fantastic. This is an evidence-based cognitive behavioral intervention. It's designed to teach children and adult skills to overcome adversity. It is the documented effects of the Penn Resiliency Program it's designed to lead to increased well-being and optimism among students, decreased depression, anxiety, and conduct problems, decreases in substance abuse and mental health diagnoses, and then improvements in physical health. There are 21 empirically validated skills that build cognitive and cognitive and emotional fitness among students, strength of character, and strong relationships. These skills, the skills that are included in each program, vary based on the needs of the child or student who's participating and the length of the program. And each skill targets one or more of these resiliency components that you see here on this slide. So there's some flexibility in terms of the intervention components that might be part of this intervention. Okay, I am going to stop sharing just for a second so I can make sure I have a short video that I'd like to share. I want to make sure I have the sound ready to go. Looks like I do. But this just highlights a little bit more about the Penn Resiliency Program.
So for the past 6 days, the staff at St. Peter's College has been working with the folks at the University of Pennsylvania to take the science of well-being, of positive psychology, and bring it to their own lives. So we've been talking about the skills of mental toughness, of character strengths, how to engage fully with the best of who you are in your classroom and with your kids. We've been talking about the science of resilience and how all the staff at St. Peter's can enhance their resilience and enhance the resilience of the boys they work with. The Penn Resiliency Program is a program that's been developed at the University of Pennsylvania. We've been using it for over 15 years in classrooms with boys and girls. And what we find is that when kids learn the skills of resilience, they're significantly less likely to get depressed. They're significantly less likely to have symptoms of anxiety. They're more attuned in the classroom. They come alive. And emotionally, when they learn the skills of PRP, Penn Resilience Project, they feel connected to what they do, they're happier, their relationships flourish. And so these are skills that we know from science are important for boys and girls to use to feel connected, resilient, engaged in the classroom. So the exciting thing about positive psychology is that it's science-based. So all of the skills or interventions, activities that we're doing here with the staff at Saints and that they'll do with the boys in the classroom, they're activities and skills that we've tested, that we know that they work. We've done many, many studies which show that when people learn these skills, they don't just feel better for a heartbeat, but these skills are lasting. They change the way the boys will interact with each other, will engage in the classroom. These are skills that the science tells us will prevent depression and enhance well-being across the lifespan. What excites me most about St. Peter's approach to well-being is that we're spending this 6 days with all of the staff from many different parts within the school for the folks to learn how to apply the skills of well-being of PERMA to themselves first. Because that enables a live it, then embed it, then teach it model. And in my experience, when that's the approach, when the folks who are going to be teaching the boys have first wrestled with the skills themselves, applied them to their own lives, then you have sustainable change. So I think it's exactly right here at Saints. What your son is learning here at Saints are skills that are not only going to benefit him today at Saints, but these are skills that are going to benefit him across his life. He's going to learn skills of resilience that will help him bounce back today, but will also help him bounce back no matter what life puts in his path in the future. He's going to learn skills that help him to have strong bonds with his mates today and to have a strong relationship with his wife later. He's learning skills that are going to help him to get good grades here at Saints and to excel in his work down the road. He's learning lifelong skills of well-being and resilience.
Okay, so this just gives, can you all hear me okay? Okay. The video is meant to just show a little bit more about the Penn Resiliency Program. Karen was highlighting how it's been implemented in an all-boys college. So certainly I think some of the terminology may not have been as inclusive as I would have liked, but thinking about ways that it could be used, right, to promote aspects of well-being in the classroom. And so is meant to be, might be a way that you could implement some of these in a school setting. Maybe some of you have had experience trying this out, but offer some ideas of ways that we would focus on aspects of positive psychology with our students as well, given that many of the other interventions we're talking about today are focused on treating more significant mental health concerns. So just wanted to balance that out with some positive psych intervention approaches too. The next intervention program we're going to talk about is interpersonal psychotherapy using the adolescent skills training. This provides, up here you can see a book that you could purchase that walks through this model as well. The focus of this is more towards high school students, so it's adolescents 12 to 16 who have elevated depression symptoms. It's a 10-week intervention that includes 2 individual sessions as well as 8 group sessions. These are designed to be longer. Again, we're talking about tier 3 interventions. A lot of times they can take a little bit longer and require more resources. It's 90 minutes once a week in a group of 3 to 7 adolescents. So more of an intensive intervention treatment. The group includes an interpersonal inventory to help students be able to assess where they're at. It provides psychoeducation about depression, discussions about how depressed mood and interpersonal events are linked, instruction on interpersonal techniques and communication strategies that students can use with the hope of hopefully improving interpersonal relationships. The intervention specifically requests that the person who's implementing it is a trained mental health professional, so psychologist, social worker, counselor, and they have a manual available that would walk through this intervention program as well. So it's a manualized program. Again, some of the things I just mentioned, it talks about the relationships between feelings and interpersonal reactions. But again, apply skills to their lives. So students who are in the group have a chance to practice these skills in group, and then they give them strategies and homework assignments to be able to implement those at home as well. This is the logic model for this. This is kind of more of a research-oriented approach of what it's supposed to, the intervention components include. So this talks about what counselors do, what are the implementation variables, and then hopefully proximal outcomes that we would expect to see in students is improved mood and anxiety, improved social functioning, hopefully greater engagement at school and attendance. And then longer term outcomes that they're seeing with the intervention is that students have improved attendance in school, improved grades, fewer disciplinary incidents, and improved school retention so that they continue coming to school, or hopefully decreasing rates of school dropout as well, and reduced onset of depression. So you can see a little bit about the design of the model and what it's intended to target, but would draw you back to the intervention manual if you're interested in learning more about that in terms of how you might implement that in your own school. And then coping power. This is a group-based intervention designed to reduce aggressive attitudes and behaviors among students, and has some evidence to support its use in preventing substance use and abuse. The coping power intervention focuses on problem solving and conflict management, teaching kids coping mechanisms, and helping students develop social skills and social support. It has been implemented with kids in late elementary grades and early middle school years. The core component, if you would deliver it as it was intended in designs, is, it sounds crazy, but it's 22 group sessions. It's meant to be one group session over 5th grade year, right? That's why it tends to be longer. But 22 group sessions that happened in 5th grade, and then 12 sessions later when students get to 6th grade. Those have been modified in different capacities and dosages across other years. As you can see, it's been implemented with kids at different ages, from elementary to middle school, but in its design, right, it's these weekly sessions in 5th grade leading into 6th grade. The meta-analyses that have been done in the multiple studies conducted on coping power has shown small to moderate reductions in students externalizing behavior concerns, and it has components of this where parents also attend a number of the group sessions so that they learn some of the skills that kids are learning in the group to be able to implement those skills at home as well. Coping power, depending upon the studies that you read, has been implemented classroom-wide, more as like a tier 2 model, and then it's also been implemented tier 3 in those with small groups of students because it is longer in duration. And can take periods of time. We're talking about kind of, again, hour-long weekly intervention sessions that last over a school year to hopefully make lasting changes with students into middle school and high school years for more of those aggressive behaviors. But you can purchase the Coping Power manuals. There's facilitator guides. It also has a parent group manual as part of it. And that's an intervention that's been around for a little bit longer as well. So if I were to dive into all of these tier 3 interventions, you all would probably, I don't know, throw things at me or not wish me very well. So we're not going to do a deep dive into all of these things, but I did want to leave you with a list of potential interventions if you're interested in learning more. All of these interventions, our team does more of a focus on internalizing behavior. So these you will see focus on depression, anxiety, and general internalizing concerns. But it does provide you with the age range of the different interventions, whether they are group or individualized. Some are both. The number of sessions and the number of session length. Again, we're talking tier 3, so they take longer, right? They're more intensive. When we put this list together and we've added to it and changed it over time, this was what we used when we were making a case for why we needed to build REP as a tier 2 intervention, because we felt like a lot of the longer manualized treatments are just difficult, right? They can be challenging to implement in schools, especially the ones that have evidence to support their use in maintaining change with students over time. But with that being said, there's a lot of really effective programs out there that can be implemented with students. I think, again, we highlighted a couple of these today just to give you a snapshot of what they look like, but would encourage you to check out some of these other ones as well if you're interested in learning more. Okay. We're going to go into cultural adaptations here in a minute. Before we do that, wanted to see if there was any questions. And then my question back to the group is, what are potential facilitators and barriers to implementing these interventions at your school? So I'm curious, do you have ways that you think would help you? When I think about facilitators, I think about do you have an intervention hour set up at your school where you get to implement groups? Do you have time set aside after school to implement therapeutic interventions with kids? Do you work in a therapeutic school where it fits into the schedule for you to implement interventions like this? And then on the flip side of that, what might be potential barriers that you would experience in trying to implement some of these tier 3 or even tier 2 supports at your school? So I see the chats. I haven't had the chat open, but I see the chat numbers are going up, and so certainly want to hit those as well.
Yeah, lots of noise in the chat. Lots of great thoughts there. Time is probably the top one I'm seeing.
Time, money, lack of mental health professionals.
Resources.
Time from admin, length of
Money.
sessions. Yeah, prep period. Purchasing. Staff turnover, yeah. There's a clear distinction between educational responsibility, therapeutic. Thank you. I'm just kind of reading through your responses here. I will say in terms of time, I don't know if I have a good answer on money. Maybe our friends in Pennsylvania have ideas for money for mental health supports more locally. But I can say in time, one of the things that we really advocated for in different districts where I've worked is having time for job alikes for school mental health professionals, and using that to address some of the needs that we would have. So, for example, in one district, we had difficulty, we didn't have a good referral list for outside services, and we found that we were getting a lot of, I might just stop sharing this while I talk. We were getting a lot of questions, or not questions, but cards from private therapists outside the community or community mental health agencies that were starting services in our community, that wanted us to refer families to them, and we didn't know them. And so it felt almost not unethical, but it was hard to make referrals to places we didn't really know what they did or who they were. And so we did spend one of our full day professional development days asking people from the community to come in and meet with us. And we did and we brought all of our social workers, psychs, and counselors together. And we just would have for half an hour, we had somebody come in. They would tell us what they specialized in, what insurance providers, and what insurance they took. They'd bring pamphlets of their services or connections to their website. And they spent time just talking with us about who they were and what they did, and allowed us to ask questions. That really helped us make some nice connections with our larger community around what mental health services were available for kids, where we didn't always feel like we had a good sense of additional referral sources, and that seemed to be a good use of time. In other districts, job alikes could involve coming together and sharing resources around, what tier 2 or tier 3 mental health services are you using? What does that look like? Having people maybe present how they're using small groups, or some successes that they've had in using some evidence-based behavioral or mental health interventions in their schools. So anyway, thinking about some of those as strategies to have time together to be able to collaborate and consult with each other can be useful.
Katie, we have a couple questions that came up a little earlier that if we can circle back for a second before we move on.
Please.
One is the Blues program versus behavioral activation, and how are they different?
I don't know if I know the Blues program to be able to answer that. I could look into it and get back to you, but I don't know if I've seen the Blues program off the top of my head enough to share more.
Yeah, that's okay.
Yeah.
The next one is, do you have any experience with DBT steps A?
Mm-hmm. I have not gone through, I know Jim Mazza's work. I have a lot of respect for what he does. I've not gone through the training, but I have read the book. It looks fantastic. I think it was more interest of time. And I have featured it when we've talked about tier 2 interventions, but certainly it could be tier 3 as well. But have only good things to say. But again, I haven't been through the training or implemented it myself to be able to say much more than that. But I know DBT has lots of promise in schools, and I know Jim has done some great work on DBT skills on its evidence base as well. So I don't know if that's helpful, but yes, thumbs up.
Be a really good thought. Do you know many resources? Know of a resource that provides a very clear connection of behavioral, SEL, mental health, and its impact on academics for school boards who believe school is simply for academics. We have some boards who need to be educated on the connection.
Jennifer, if you want to send me an email, I just put my email in the chat. I can send you some resources that we've shared with the others. And I could even send that to Bria if you want to include it in the connection for today. But just some advocacy resources for those who have used it in advocating for more school psychologists or social workers. I think it would get at your question, but it talks a lot about like, what do we do? What kinds of things, like what is the benefit? What's the connection between improved mental health outcomes? Like how does that lead to improvements in academics for students? So I'd be happy to share. Yeah, and I'll send it to Bria. I just don't have a quick access
We'll
to
add
it.
it to the Padlet,
And then we'll
the
add it to the
resources.
Padlet.
Yep, just keep
Absolutely.
that Padlet link.
Definitely. Thanks, Carrie. And I will check out this blues program. Thanks. I hadn't seen this before. I just Googled it. It's nice that we have the internet. I make myself sound so old. Any other questions, Bria, that you think would be helpful to answer before we move on?
Seeing any right now.
I know. I just looking, Heather, thanks for your comment about like our school has SEL as a related arts that's scheduled each week with a specific curriculum. Like for students who need tier 2 or 3, it might be a good time to pull for more intensive intervention. That's very cool. Yeah, the missing class is tough. We just, in our local district, we have a pretty active CBITS and bounce back program. If y'all are familiar with that, well, some see it as tier 2 or tier 3 for cognitive behavioral intervention for trauma in schools. And we have community mental health providers who co-facilitate groups with school employed mental health professionals. And we have found in the last couple of years that there's more seats available than kids who are filling those seats. So we did a project on youth voice and trying to learn from our youth about what were like barriers and facilitators to accessing mental health care. So what were reasons kids came to group and wanted to keep coming back to group, and then what were reasons that kids didn't or chose not to participate even when they were eligible. And one of the top reasons, two things that came up. One, kids didn't want to miss class. And so we had, 16 different focus groups of middle schoolers and high schoolers. And many of the kids said, like, can you offer groups after school? Can you do groups over the lunch hour? And I can bring my lunch to come. Like, I want to come, but like my grades are really important and I don't want to miss class. The other was that kids didn't understand the ask. When they met with the school psych or social worker at their school, they didn't know what the group, they didn't have enough details about the group to make an informed decision, or they didn't know the person who was asking them to join. And so it was almost like the culture and climate of mental health at the school either was like a barrier or facilitator for kids participating in supports. And again, that's not like pointing the finger at the social worker or psych or whoever saying like they weren't doing a good job, but it gave us some more information about like what can we do to talk to kids about these groups and about services at school so they had a better understanding of what they were signing up for. So I don't know if that's helpful or useful to you all, but I know our mental health team has been trying to think a little bit more outside the box about how and when we're providing services, and we have like a youth mental health advisory committee that we've developed that's been super helpful in brainstorming some out of the box strategies too. Okay, great. So we'll go ahead and keep going because we've got some more to cover before we wrap up for today. Thank you all for hanging on. I know it's getting to be the end of the day. Okay, and I'll try to keep the chat up, but feel free to interrupt Bria and others if more questions come up. That's great. I love the lunch and learns too. Okay, so we're going to talk about cultural adaptations to interventions. So whether you're using one of the tier 3 supports that we talked about, many of you probably have other small group supports with students or meeting individually with students to provide interventions, which is great. I wanted to highlight today ways that you can adapt or change your intervention to make sure that they're best meeting the needs of your students. We know that youth come to us from diverse and often intersecting identities, cultures, and backgrounds. And so these certainly are a few of the prominent identities, but there's so many others. And the interventions we deliver, it's important to take these identities into consideration in how we are implementing evidence-based interventions as well. So it's also important to remember racially and ethnically minoritized youth are less likely to receive mental health services and more likely to receive services that are ineffective or inadequate. And so cultural adaptations have been found to be one way that can increase engagement and treatment acceptability for individuals from marginalized communities who often may be hesitant to seek out support as well. Cultural adaptations are seen to be an approach to service delivery that focus on components of treatment. So what are the attitudes towards services? What are the beliefs that are being conveyed in the services and interventions that we're providing? And what are the behaviors that we're seeking to shape or change as part of interventions that we're delivering within schools? When you're making cultural adaptations, especially to evidence-based practices, it's important to think about how we maintain the integrity or fidelity of the intervention and the core components, how we kind of maintain that core component of the intervention to keep it in place and intact, right? Because that's what usually leads to promoting positive student outcomes. However, there are malleable factors of an evidence-based intervention that can be adapted without negatively impacting those student outcomes. One of the things we talk about might be horizontal adaptations. Those would be adaptations aligned to student factors, so things like culture and contextual factors, so how the intervention is being delivered. That might be changing it from in-person to a virtual. It might be who we're having deliver the intervention and thinking about who is participating. These are things we might change before the intervention begins. Vertical adaptations are things that are made in response to the intervention starting. This is our data-based problem-solving approach, where we might be examining data to determine if the target behavior is changing in the direction we want it to, or the skill has increased, decreased, or stabilized. If the student is making progress, right, we might start to engage in fading procedures in that intervention. But if a student is less responsive, for example, to that intervention, we might make adaptations to intensify. So we might do things like increasing the dosage, providing increased rates of feedback. Our schedule of reinforcement might be increased as well. And so thinking about ways that we can make those changes. So surface structure adaptations involve changes to materials and activities based on observable components of a population's culture. So we might think about what are the pictures that are included in an intervention? Is this intervention appropriate for students from second language backgrounds? Are there concepts that we need to provide differently or describe differently? We might think about music. Deep structure adaptations address things at deeper levels, right, around core values, norms, and beliefs. For example, within the resilience education program, after each lesson, we talk about different cultural adaptations you can make. One of the things we discuss is when we talk about strong feelings, different families have different expressions of anger, right? And so thinking about how do we address some of those core values, norms, and beliefs when we're talking with students about differences across families. So I'm not going to do this just in the interest of time, but thinking about what cultural adaptations have you made or seen in your schools or practice. If you want to drop any of these in the chat, I'd love to hear what those look like as we're talking today. If anything comes to mind of things you think might be helpful to others, that would be great. Cultural adaptations, when are they needed? So certainly I gave some ideas of you can do them before, or maybe you're making them when the intervention started in order to increase student engagement. Typically the low student engagement, right? If we find that students don't want to come to group or they're hesitant to come, oftentimes we joke, but like food can be a good motivator to keep kids coming to group. When we met with kids in our focus group, food came up consistently. And that sounds silly, but like that doesn't mean that that's what a kid learned about was like how much I love having a jelly donut. But that's what got them in the door, right? And then perhaps they learned some skills while they were there. Many of us know, like playing games with students, right? When a student's distracted and playing a game with you, they're a lot more comfortable just talking about something than, hey, you're going to sit here, 9-year-old student, and have a adult conversation with me about something really serious. They're much more likely to, when we have that parallel activity that we're engaged in, that parallel play, for me to learn a little bit more about you. So thinking about how we help students feel comfortable as well. And then culture-specific factors that can potentially impact intervention outcomes. And I'll give you some examples of what these look like in our field. A couple different levels of cultural adaptations are here. So at the practitioner level, making sure that as a practitioner, you have a cultural understanding of the students and families that you're working with at your school. At the program level, what does the delivery of intervention look like to students? So what kind of intervention programs are we putting into place, and do those match the needs of our students? And then at the organizational level, to accommodate the culture of a population within organizational policies. When we talk about cultural adaptations in the field of school psychology and social work, these are examples all from school psychology researchers of cultural adaptations that have been made to social emotional learning and mental health interventions. Sara Castro Olivos does a lot of research on cultural adaptations, specifically to the Strong Kids and Strong Teens curriculum, and has done research on how to adapt that intervention to meet the needs of high school Latinx students with really effective outcomes. Lexi Barber was a doctoral student of mine here at UW-Madison, and she took our REP intervention that I talked about earlier, and she ran affinity groups with Black students in a middle school setting, and she did a mixed method study where she evaluated cultural modifications and cultural relevance of REP for Black middle school students who had internalizing behaviors, and got feedback from the students and from families about how to make improvements to it, and the ways that the modifications she made, did they feel like it really met the needs of the students who were in that group, which was fantastic. The second step curriculum was adapted for Black male students in an elementary school by Scott Graves and colleagues, and they talked about a number of the ways that they adapted the intervention and made some positive changes, which led to increases in students' social engagement at school. So what does the cultural adaptation process look like, and what are some ideas of ways that you might be able to do this? Certainly this is a formal cultural adaptation model that talks about, what is your target population, how might you collaborate and get feedback from families and communities of ways to adapt. That might be like an SEL curriculum that you're thinking of implementing in classrooms. Could you adapt the current intervention to reflect feedback from the larger family community. You would then implement the adapted intervention, evaluate outcomes, and then make further adaptations using ongoing evaluation and collaboration. For many of you who are strapped for time, that might be more difficult to engage in this kind of process. And so certainly want to offer some ideas of ways that you could do this. I'm going to skip ahead here. Okay. Ways that you could do this in your school, or give you some ideas. There's a few different common cultural adaptation models that are out there. The cultural sensitivity framework is the one that talked about sensitive and deep, or surface and deep adaptations that we talked about before. That's in the middle. The one on the right, we're not going to dive into today, just in interest of time. But on the left is the ecological validity framework that came out of the work of Bronfenbrenner, but was adapted by Bernal. And this framework lists 8 broad areas that we'll walk through for considering for ways that you can culturally adapt an intervention. It looks at things like language, who's involved, the metaphors, the content of what you're teaching, concepts and goals of the intervention, how you're delivering it, and then in what context. And so certainly these might be things, ways that you can, here are the 4 different strategies. These might be ways that you can implement some of these changes as well. The original model that Bernal developed was applied for use with individuals from Hispanic and Latinx backgrounds, but at the time, and certainly in subsequent research, we've seen that this model has been applied with other racial, ethnic, and linguistic groups as well. Okay, so what does this look like? The first is language, right? Click again. Language would refer to oral and written communication. Persons would be practitioner and student variables, so who's included. So, for example, school mental health professional and the students, thinking about that. Metaphors would be the use of symbols, concepts, and language metaphors. And then content would be cultural knowledge, values, and traditions that are embedded within the intervention. So across these 4 ideas, here's some ideas of what that could look like with examples of how you might modify your intervention. So a language differences might be translating your intervention into multiple languages. That's the most straightforward adaptation. It might be omitting clinical terms. So instead of calling, we might describe something like strong teens as stress reduction, right? Instead of a mental health intervention, we might refer to it as stress reduction for teens. Language might also be the use of preferred pronouns for students when they introduce themselves, giving kids the option to also use their preferred pronouns if they wish. When we talk about persons, we might think about an affinity group, right? Would there be a way that we would have students all from a shared identity in the group come together, or those students who have a shared identity with the facilitator? We might think about, I've seen groups run for students that are part of military families, right? For students to talk about what might be shared identity considerations that kids want to come and talk about that is relevant to being a part of a military family as well. Peer-mediated interventions to improve social skills, right? So I gave you an example of what that could look like within check-in, check-out. Using cultural metaphors of the target group, being able to say, do I see myself reflected in this curriculum, right? So for students who are in part of Native or Indigenous communities, the use of traditional images to talk about different concepts that we might be talking about in the group Other metaphors, right? Do I see myself reflected in this intervention? Are there examples that are relevant to my own life? I think having smaller groups where you're thinking about 3 to 5 students, it makes it more possible to really, I think, dig deeper or drill down to consider what are the individual identity considerations of the students in the group. And that could be in the vignettes that you're using, in the different video examples that you choose to highlight in a particular intervention. That can be useful to spend time on before you get into the group ahead of time to make sure that kids really feel like they're seen and they're valued and they're heard. And then content to incorporate example scenarios and stories from students' culture, right? We're just talking about this, allow youth to identify race and or identity-based discrimination and brainstorm coping strategies as well. Our local Journey Mental Health is our local partner who runs our CBITS and Bounce Back groups, and they do a lot around race-based discrimination and have a whole unit in that as well for students where that might be more relevant. That's been a way that they have modified some of the curriculum to make sure that it's relevant to students as well. So that gives you the first 4, and then the last 4 components of Bernal's ecological validity framework talks about concepts, goals, methods, and context. So concepts is aligning theory with the belief system of students and families. Goals, we want to make sure the goals of treatment align with students and family values. Methods, right? How are we engaging in problem solving and thinking about aspects of cultural congruence? And then context, what is the social and political context of our clients? This is tricky, right? We're in a time that's really politically heated and challenging to know, can we talk about some of these things within schools without expressing maybe a certain political preference? So what are some concrete examples of ways we can do this? Certainly, we might, as far as concepts, work with family members and community members to divide concepts and what success looks like. We might incorporate role models. So, or think about who are mentors in the community or trusted adults. I worked in a high school that was a predominantly Black and African American community. And following a crisis event, we had local religious leaders come in to provide support to kids in our school after a shooting had happened in the community. They were an especially helpful support system to our students and role models and trusted adults that the kids felt comfortable going to. So thinking about ways to implement that into our programs and practices as well. Co-constructing goals with families and involving families in assessing progress towards goals, right? When we start a new intervention program, we spent some time today talking about a variety of tier 3 interventions. We have to get consent from parents, right, to run groups. We didn't spend a lot of time talking about that or any time today, but when you send that consent form home or reach out to parents, that can be a great time to spend some time asking, what does this look like at home? What are some of the goals and dreams that you have for your child? Like I said before, I think a lot of times we assume that how a child acts at school is how they act at home. That's often not the case. And so making sure that we are engaged in some planning with families to better understand how we can support their child at school as well. Methods. So as we think about our own individual and small group supports, we want to be able to align activities with cultural norms. So thinking about incorporating group activities and peer support, that might be during homework activities. We might think about ways that we modify mindfulness activities. Somebody pointed out once to me before that body scans or mindfulness can be difficult for individuals who have eating disorders or disordered eating. And so thinking about ways we might modify it to make it inclusive for students who are struggling with difficulties in that area as well. And then finally, context. Consider specific life and family circumstances, such as acculturation factors or experiences of marginalization or discrimination. So things like motivational interviewing might be used to ensure that our interventions align with the goals of our client, learning more about what's important to them and helping them identify to do some self-directed goal setting can be useful too. Okay, so we went through that pretty quick. Any questions on cultural adaptations before we move into progress monitoring? Okay, I'm wondering about coupling cognitive and behavioral skills development programming with explicit intentional relationship, like tier 1 training for staff and tier 3 like check and connect. I think that's great. I love all of that. I mean, I think it, food and game, sorry. I think I think that is a nice combination of both thinking about what are universal practices that support all students, as well as how do we, for those students who maybe don't feel like they have the positive connections at school, how do we help support that and build that in a more targeted fashion? I think that makes a ton of sense. I know my brother is a school principal, and one of the things that they've done at their school at the beginning of the year is they create a class list and they have of all the students, and they have teachers do like dots or a check mark after every single student of who do they think that they have like a positive relationship with or a close relationship with, and then they look at their list to figure out which students didn't have any check marks next to their names, which students weren't identified by teachers as having a close relationship with an adult at school. And then they purposely assign like teacher mentors to those students to help them build purposeful relationships with the students throughout the year. And so I see some of the stuff you're talking about here as that intentional relationship building, and thinking about, check and connect as being maybe that more tier 2 or tier 3 intervention that can be useful for kids who don't have some of those positive relationships at school. I think that's fantastic. Okay. Progress monitoring. So we have about 10 minutes left. I'm just going to go through this in about 5 minutes, and I'll leave some time for questions at the end. One of the most common questions I get, and I may even just skip forward to slides to make sure I hit this, is what are good evidence-based progress monitoring tools for mental health interventions that we're using at school, right? When we think about progress monitoring, we want to monitor, right, how effective is our independent variable, our intervention on impacting student behavior. And so we need to think about finding good tools, the design, our procedures, our analyses. The difference between academic screening and progress monitoring is there's many differences between academics and behavior. Screening and progress monitoring for academics you often can use the same tool. So when we think about things like oral reading fluency, right, we can use those for both purposes. Behavior, those are different tools. Our screening measures, for example, were not designed to be used as progress monitoring measures, and often they're not sensitive enough to change to be implemented in short term, in that like 4 to 6 week time period where we would expect to see changes happen. So those are usually different tools. Same with our data collection periods. For academics, that's every 1 to 2 weeks. For behavior, sometimes we need that data every day or once a week. So again, we're thinking about different tools can do that. And our baseline data collection also looks different in those in that time period. When we are identifying effective progress monitoring tools, we want to find defensible tools that have good reliability, validity, and treatment sensitivity, that are low cost, time, and effort, can potentially be used multiple times a day, and that can assess a wide range of behavior. These are a couple of tools that don't have any evidence to be used as progress monitoring. That doesn't mean they're not good data sources to tell you something about a student, but things like office discipline referral data, comprehensive rating scales, and universal screening tools weren't designed to they're not sensitive enough to change, to capture change in a short amount of time to be a progress monitoring tool. Other tools that are out there that have limited evidence would be daily progress reports and brief behavior rating scales. And those that have the most evidence would be systematic direct observations like classroom observations and direct behavior ratings. Some examples of systematic direct observation forms would be the behavioral observation of students in schools, or the BOSS. The state event classroom observation system is another one. These are objective measures that have solid psychometrics to support their use in progress monitoring. Some of the challenges are, as you all know, they can be time intensive, right? They can be a lot to find the time to go and observe students in classrooms, and often require specialized training to use. Some of the other brief rating scales that are out there, these are often used as pre-test and post-test measures following students' participation in an intervention. And these are short forms derived from longer scales. So the social skills rating system, the peer conflict scale, and the children's depression inventory, they're brief, they come from a trusted source. They have some evidence, but they don't have a lot. And so certainly we'd want to have more research on these as progress monitoring measures. Usually they're more oriented towards like pre and post test measures. One of my favorite progress monitoring measures out there is the Behavior and Feelings Survey. This is created by John Weiss, who's out of the University of Harvard, or Harvard University. It's a 12-item measure. It has both a youth and a caregiver form, and it assesses both internalizing and externalizing problems. This is it, like what you see on the right. There's 6 items that assess internalizing and 6 items that assess externalizing items. And it gives you a total behavior scale as well. And it can be administered once a week. We have used this in our in a lot of our REP studies on our Tier 2 intervention, the Resilience Education Program, and in some other studies as well. And we find that we do see some variation in student ratings of their own behavior. I also like it because it's a student self-report form. So if you're facilitating a group and you have a group of students who are coming to meet with you, you can have them fill this out either before or after the group to get a sense of how things are going for them. It's not, you certainly could also have a parent fill it out, but it's not giving it, it's not another thing for a teacher to complete. That takes some additional teacher time. So this offers some useful feedback, and this is a link to where you can find that measure. It's freely available, and it tells you how to score it and gives some more indication of what that looks like. Another good rating scale is direct behavior ratings. This combines systematic direct observations and rating scale methodology. Sandy Chafulias at the University of Connecticut and her team and others have done a lot of research on this. It's meant to be a brief rating on an operationally defined target behavior in a specified observation period. And so there's multi-item scales and single item scales. But this is what that form looks like. This 3 core behaviors are academic engagement, respectful, and disruptive. And so it provides a definition of these 3 behaviors. It has teachers can, for example, once a week or maybe even once a day, provide quickly what percentage of total time in the classroom is the student academically engaged? Are they respectful? And are they disruptive? And so it gives an indication. I've used this in studies where we've emailed this form to a teacher to provide ratings. They can go and click, 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 and it automatically through, I don't remember if we use Google Forms or a Qualtrics survey, sends us some quick feedback on how students are doing on these 3 behaviors in the classroom, giving us some good progress monitoring measures for behavior. In Wisconsin, we're required to document progress monitoring data on mental health and behavior interventions prior to diagnoses of emotional disabilities now. And so we find that a lot of our practitioners are needing to use some of these, I'll continue to share, needing to use some more of these tools more often than they have in the past. All right, so I see we just have a couple minutes left. I'll just point you to a few resources here before we break. I have highlighted these before. This is the rep guide and our screening guide. There's also a consultation resource guide on smhcollaborative.org. We wrote a book on screening that's there, but this is my email. That's a part of the slide deck as well. If after today you have other questions or would like to talk more, please feel free to reach out. I'm happy to stay in touch. Otherwise, thank you to the Pennsylvania team for inviting me to join you. I know we went through a lot of information in a really short amount of time, but thanks for the invite to be here, and I'm happy to stick around for a little bit and answer any questions.